All right. Are we live? Yeah, we're live. Okay, fantastic. All right, well, thanks everybody for going out to the exhibit hall and our very important sponsors here. Appreciate that. I'm Middleton Chang. I'm one of the surgeons at Emory at St. Joseph's, and
I'm Emily Lodgegren. I'm one of Dr. Shavu's partners up in Marietta, Georgia.
so thank you all for returning from the break. We will get started here with our first presentation. If Dr. Bott wants to come up, we're doing a little bit of audible here, so Dr. Bott will be presenting first. Reminder that we do have the Slido for questions, so please take a look at your QR code. It's in your manual, and you can submit your questions and we'll put them up there at the end of this talk. So our first talk today is the endovascular repair of a popliteal artery injury after arthroscopic intervention, presented by Dr. Bott. You gotcha.
You got it.
Good morning, everyone. My name is Carter. I'm a fourth year doctor with that. Thank you to the Vascular Society for allowing me to present the fall this year and the vascular experience the location of the popliteal artery is compared to each aspect during our trial. Here we report the case of the popliteal artery after our process. Is the field after PCI here and currently on after capital. Other than the previous he presented 8 days after some information he developed a rear pain with fall he presented around on physical then the one that he had to do so right allowed to use get really well and really involved in the right it was not a to the pole and there are also the under our supervision on the right platform. We also mentioned the right needs to it also improvement of here and then the main possible for the plan to mention the following day. So the other one is the right of the and we never given the possible artist to the he was impressed also on the side 7 by 5 by on spectrum and it has application of the problem of security false. You are a right of giving and so use possible way in addition to our same day present back plan on and improvement in select pages following on the net. Physical exam, still have a little bit of plus one there's no massive space, we don't think we can and no problem that present. He had a 2 plus 8 I'm going to do with the things that and go to that and he would follow installing massive at resolution and at resolution he was very he had possible pulses, ABI, these reflex will lower the analysis. So actually, reflex here, so this is a three stats. So handing flow, ground, ascend, and spinning, and then staying output. So we just and the vascular repair was standard that will show you that. This case is right, that's one vascular repair, which does appear to stay in the effective way to treat actual vascular operation. Then you don't look at
Thank you, Dr. Bott, for your presentation. And once again, Slido is open for your questions, or you can come up to the microphones. We got one on each side. Dr. Bott, what do you think the generalizability of this technique is to non-iatrogenic trauma?
So stenting is used for optical artery aneurysm. Treat that, especially in patients with a lot of inflammation. The main thing is close follow-up with these patients. These stents are in can be placed through a hinge point, a flexion point, like the knee. So it's close follow-up is needed.
All right. Any other questions from our moderator or the audience? All right. Thank you, Dr. Bott.
So next we have Hannah Van Patten, who's a surgical resident PGY3 at Memorial Health University. And she's going to present today on arterial thoracic outlet syndrome in a pediatric patient, a case report.
Good morning. I'm Hannah Van Patten. I'm a third-year general surgery resident at Memorial Health University Medical Center in Savannah. And I'd love to thank the Society for having me today. It is my honor to present this case report of arterial thoracic outlet syndrome in a pediatric patient. I have nothing to disclose. So thoracic outlet syndrome is characterized by symptoms related to compression within that small anatomic space. And the subtypes include neurogenic, venous, and arterial subtypes. The arterial pathology by far is the most rare of the three, and it's seen in only 1 to 2% of all cases. It is almost always associated with a bony abnormality. This affects both genders equally, more commonly in young adults, actually. And the vast majority of patients report a history of either trauma or chronic repetitive stress during sports or work that often include overhead arm motion. So I have an anatomic diagram here. On the left, we see the scalene triangle, which is the most common area where the neurovascular bundle experiences compression. And here, the bony abnormalities can be are represented, and we sometimes see an anomalous first rib, sometimes cervical rib, which may or may not be fused to the first or second rib. You may also see scalene hypertrophy, and other etiologies may be a prior trauma of the clavicle or of the cervical spine, for instance. Symptoms that patients report include chronic pallor. They have hand or arm pain that is exacerbated with activity, as well as coolness and lack of pulses. The diagnosis is essential to have symptoms of ischemia that are reproducible with activity. However, CT and MRI or other cross-sectional imaging are essential in the diagnosis as well. Uncommonly, acute thrombosis can lead to limb-threatening ischemia, and unlike the other subtypes of thoracic outlet syndrome, surgical decompression is more frequently required in arterial TOS. So our case is a 13-year-old male who presented 5 days after sustaining a right elbow injury, and as a highly competitive baseball pitcher, was experiencing numbness and pain of his right hand, his dominant hand. On initial exam, he was found to have a lack of pulses as well as hand pallor. This is our initial arterial duplex obtained, which shows a patent right brachial artery and occlusion of the radial and ulnar arteries. CT angiogram was obtained next, which showed signs of compression of the subclavian artery within the thoracic outlet. If you look closely, you can see some hyperdensity there at the proximal subclavian. And these are 3D recons of that same study, which demonstrate a right cervical rib, which is fused to the second rib. We then obtained arteriography, and demonstrated here is a lucency of the subclavian artery proximally, which is exacerbated with provocative maneuvers. The same arteriography reveals patency of the brachial artery. And distally, we see occlusion of the ulnar and radial arteries with reconstitution of the distal radial artery via the interosseous artery. So this patient then underwent an attempted aspiration, thrombectomy, and thrombolysis of the right radial artery as well as the ulnar arteries. Unfortunately, it was not initially successful, and he did undergo balloon angioplasty as well and was initiated on therapeutic anticoagulation at that time. However, his symptoms did persist, and with ongoing claudication and coolness, he was next referred to Dr. Freischlag at a vascular center of excellence for thoracic decompression. Dr. Freischlag performed transaxillary resection of the cervical rib and a portion of the second rib with intraoperative angiogram, which I will show next. His case postoperatively was complicated by right hemothorax, which was successfully managed with chest tube drainage over 3 days. This first image is the arteriography showing a patent subclavian artery, brachial artery widely patent. And distally, we see occlusion of the radial artery with some flow within the ulnar and interosseous arteries, which will become relevant. As he recovered, his postoperative course progressed well, and his symptoms were continuing up to 3 months later. So after surgical discussion and consent with his parents, the patient next underwent a right brachial to ulnar interosseous artery bypass using reverse saphenous vein graft. I have here a diagram of our operative anatomy with our reverse saphenous vein graft between the midbrachial to the ulnar and interosseous. Intraoperatively, he was noted to have chronic thrombosis of that right radial artery. The follow-up at 8 weeks showed excellent patency of his graft, and his symptoms continued to improve. In conclusion, adolescents present more frequently with arterial or venous thoracic outlet syndrome than do adults. And more often, the surgical decompression of the thoracic outlet and removal of bony abnormality is more and more paramount to the treatment of this disease. The subclavian artery in adolescents, fortunately, is often undamaged and almost never aneurysmal as opposed to adult patients. And in nearly all adolescents, treatment with surgery does result in rapid return to full activity. This case was very unique, and it represented a difficult anatomic presentation. Afterwards, although his hand was viable, delayed bypass did result in improved symptoms eventually. And this patient has done excellently when it comes to his return to activity, and it has really required a multidisciplinary approach using long-term physical therapy, which is required, or recommended rather. Thank you so much for this opportunity. I'd be happy to answer any questions at this time.
Thank you very much. Being that he's only is this on? Being that he's only 13 years old, what is your concern about the contralateral arm or surveillance that you would want to recommend for him?
Certainly. Contralateral disease is uncommon usually. It's typically a unilateral presentation for arterial outlet syndrome. On his imaging, we don't see a significant bony anomaly on the left. However, it is important to follow up every 3 to 6 months in the first 2 years. And as he continues to grow and mature, I would suggest that annual follow-ups would be recommended.
Any questions from the audience? Dr. Freischlag?
Yeah, I think this is a great example of what Dr. Canonas was talking about with look, listen, and feel. No one thought anything was wrong with him because he was 13, right, to do it. And it went on for a few months with embolization. I've never seen so much distal thrombosis in a 13-year-old with this. You could actually even see the cervical rib in his neck. So if you looked, you could see that with the artery pulsating if you looked. And then certainly if you felt, you would feel no pulses in his arm. And we did an angio on the table, gave him a little heparin that caused the bleeding because we were hoping we could dilate that distal artery. And we also wanted to make sure that subclavian artery was okay because it was really displaced by the big cervical rib there. But this is a great combination of getting together to make good plans for patients because they were very qualified to try to open it, do the bypass, but felt that we should do the rib resection. And the parents were just great going back and forth. And I see patients from about a 6-state area in North Carolina, again, showing the systemness approach.
Dr. Jordan?
Can I ask you-
Augusta?
Yes, can you go back to the microphone for us, Julie? I wanted to hear your thoughts about the transaxillary versus supraclavicular. I know that you've been an advocate for transaxillary and I use it in some circumstances. I'll confess that I typically go on after the artery, I'm going supraclavicular and you did this transact. So I'd love to hear your thought process.
Yeah, my partner, Randy Gary, does all his infraclavicular, and we actually looked at his venous patients versus mine, and they do just as well. The key is you got to get all the rib out. In infraclavicular or supraclavicular, you have to worry medially, and transaxillary, you have to make sure you go posteriorly to make that happen. I've actually gone away from replacing the artery. We didn't think his artery was abnormal, but if you did need to replace it, I would have gone supraclavicular and put in a short bypass graft that you can. I don't think it makes a difference if it's PTFE or vein. I actually sort of like PTFE better, but it's got to be really short or because of the motion, they'll lose it. But I think the outcomes are just as good. You know, Greg Pearl does all his supraclavicular. He has great outcomes. So does Rob Thompson. So Herb just taught us to do it this way, and that's my comfort zone.
I think I saw an ESPN video where a gentleman named Hartman had a supraclavicular and your picture was featured there. I don't want to ask you to disclose any PHI, but you still use.
Well, his was very, no, he's talked about it. Actually, I was on game day last week again. I was just real excited.
I
Did
saw
you see
you.
me?
Congratulations to you. I saw you.
And actually, one of my presidents is from Alabama, and I suggested since you're not doing so well, that somebody should have their rib out. But anyway, so I was on game day last year on New Year's Day. I actually got a bunch of texts to it. So he had an infected thyroglossal cyst when he was 16. So that's that incision. And then he thrombosed his arm, and it was his non-throwing arm. So he had like chronic venous insufficiency when I saw him. And his dad's an orthopedic surgeon. His mom's a PACU nurse. His brother goes to Gainesville Medical School because, of course, we wouldn't let him into our medical school. So it was very complicated. So we did the rib resection, and frankly, it was scar tissue all around the scalene. So that's why we did a venogram, we dilated the vein. And that's why he played a month later, because I got a lot of grief from all of you saying, how are you letting him go back? But it was his non-throwing arm. But his first game, God bless him, he goes there, he throws, then he starts tackling, then he starts running, just like that. But now he's at Notre Dame, so it's very complicated. So November 18th, Wake Forest plays Notre Dame, just saying to make it.
I hate to halt the discussion on this, so let's continue it at the lunch. Unfortunately, in the interest of time, we're gonna keep moving, but thank you for an excellent presentation, Dr. Rampart. Our next presentation is a case report of giant splenic artery pseudoaneurysm associated with mononucleosis, presented by Dr. Kippenberger from Dwight D. Eisenhower. Can we have her, there we go.
Okay. Morning, everyone. My name is Captain Tiffany Kippenberger. I'm a PGY2 general surgery resident at Eisenhower Army Medical Center. I'll be presenting a case report of a giant splenic artery pseudoaneurysm of unknown etiology. I have no disclosures. So splenic artery pseudoaneurysms are rare entities. There's only about 200 cases described in the literature to date. The splenic artery is the most common site for a visceral artery pseudoaneurysm, accounting for about 46% of all cases. There is a slight male predominance, which is in opposition to aneurysms, which are more common in women. The most common risk factor by far is pancreatitis. However, trauma and instrumentation, as well as pancreatic cancer, can also contribute. These can be asymptomatic or present with abdominal pain, hematochezia, and melena. Sizes have ranged in the literature from 0.3 centimeters all the way up until 17 centimeters, with giant pseudoaneurysms being described as greater than 5 centimeters. CTA is the best imaging to look at these entities. It will show a contrast-filled vessel wall outpouching of the tunica, intima, and media, as opposed to an aneurysm, which includes all three of the vessel layers. Their risk of rupture is about 47%, and this risk is unrelated to pseudoaneurysm size. Therefore, all of these entities should be treated. If it does rupture, mortality risk reaches near 90%. Pseudoaneurysms are also more commonly rupture than aneurysms do. So endovascular treatment has become the preferred treatment modality, with efficacy reaching over 80%. A variety of coils, plugs, thrombin injection, splenic artery ligation, or stent grafting can be used. However, if the patient is unstable, open ligation of the lesion is required. So our patient was a 35-year-old male. He presented to our facility after a 12-centimeter splenic artery pseudoaneurysm was incidentally found on a CT scan done at his home institution. The scan was performed for elevated liver enzymes in the setting of a hospitalization for new onset diabetes. The scan also showed 2 cystic lesions in the head of the pancreas that were possibly representing intraductal papillary mucinous neoplasms, or IPMNs. His past medical history was, for the most part, non-contributory. He did have the new onset diabetes, which originally brought him into the hospital. He had no past surgeries. He did have a 15-pack-year smoking history, but he had stopped 6 months prior to presentation. And his family history was negative for any connective tissue disorders. Upon presentation to our facility, his only complaint was polyuria. He denied any history of trauma and denied any other symptoms. His physical exam was wholly unremarkable. His laboratory workup showed a hemoglobin of 8.2, as well as a slightly elevated AST, ALT, and ALP. He had a non-reactive hepatitis B panel and a positive monoscreen. The CT scan was reviewed with our attending vascular surgeon, and no active hemorrhage was noted. So here is the original CT scan. You can see the pseudoaneurysm coming into view now, compressing the surrounding structures of the stomach, the bowel, the pancreas, part of the liver. You can see the mural thrombus, as well as a small amount of contrast within the lumen. And this splenic artery was measured at 12 centimeters. So the patient was hemodynamically stable, so he underwent an angiogram with vascular surgery the following morning. Intraoperatively, the pseudoaneurysm was found with no active extravasation. There was normal antegrade flow into the spleen. We made multiple attempts to access the sac itself with wire. However, this was unsuccessful, so we instead embolized the inflow and outflow of the pseudoaneurysm neck in the sandwich technique, with detachable coils. And then a completion angiogram at the end of the case showed complete occlusion of the aneurysm. So here are some images from the procedure. You can see the inflow and the outflow vessels, as well as the tortuosity of the splenic artery. The left picture showing proximal and distal cannulation of the inflow and outflow vessels, and the picture on the right showing the splenic arcade, as well as more of the tortuosity of the splenic artery. And then here is distal coil packing. So we started distally, placing our coils, and then worked proximally back into the inflow vessel. And then this is completion of the coil placement. Again, showing the tortuosity of the vessel, which is why a covered stent was not placed. So postoperatively, he was admitted to the ICU for 1 night of observation. He recovered very well. He was tolerating PO intake and had minimal pain the night of presentation, or the night of the procedure. On post-op day 2, he was stable enough to be transferred to the floor. We obtained a CTA to try to rule out complete occlusion of flow into the sac. However, due to scatter from the coils as well as the recent contrast use, this was equivocal. So we ordered a mesenteric duplex ultrasound, which did show a thrombosed pseudoaneurysm with no continued flow. On post-op day 3, he was cleared for discharge back to his home institution with strict mononucleosis precautions, as well as follow-up for his newly discovered IPMNs. An MRCP was also done post-operatively, which showed a decreased size of the splenic artery pseudoaneurysm, as well as stable size of the cysts in the head of the pancreas. He was referred to the medical evaluation board due to lifelong insulin dependence, which rendered him inactive for deployment and therefore inactive for active duty service in the Army. So again, common etiologies of splenic artery pseudoaneurysms include pancreatitis, trauma, instrumentation, and cancer. There have been some less common etiologies described in the literature, including babesiosis, connective tissue disorders, fibromuscular dysplasia. However, in our patient, it was unclear to us the etiology of this pseudoaneurysm, as he had none of these common risk factors or etiologies, as well as none of the even less common ones that have been described in the literature. With regards to mononucleosis, there was one case report that I found that discussed a splenic artery pseudoaneurysm in the setting of a positive EBV test. However, that patient was also a cocaine user, and they attributed the pseudoaneurysm to cocaine use in that entity as instead of the EBV. Another case report I found was in a patient with a pseudoaneurysm associated with an EBV and a babesiosis test, positive test. Again, they attributed the pseudoaneurysm to the splenic sequestration of Babesia infected erythrocytes and not to the mononucleosis. Likewise, there have been no cases of IPMNs contributing to a splenic artery pseudoaneurysm, although it has been found that longstanding pseudocysts in the pancreas can cause or contribute to pseudoaneurysms due to erosion from the enzymes into the vessel wall. No cases of diabetes that we have found contributed to splenic artery pseudoaneurysms as well. We did consider that this patient could have an undiagnosed connective tissue disorder. Unfortunately, because of his newly diagnosed diabetes with insulin dependence, he was medically discharged from the Army. So follow-up of his medical records have become a little bit more difficult for us. However, he is in the process of getting genetic testing for connective tissue disorders. So in conclusion, we present a rare case of a giant splenic artery pseudoaneurysm of unknown etiology in the setting of an atypical triad of newly discovered IPMNs, diabetes, as well as mononucleosis. Thank you.
Thank you for excellent presentation, Dr. Diffenberger. And we will go ahead and conclude session A in the interest of time. And I believe President-elect Dr. Woody up next. Thank you.
Thank you.
We're going to bring Dr. Shabu's family in, so give us a few minutes. Come on down. You're the next contestant on The Price is Right.
So it is my privilege to introduce the 11th president of the Georgia Vascular Society. The story of our president begins in southern India, exactly 9,004 miles from where we are right now. Mysore is a city rich in culture and is also known as the city of palaces. More importantly, it is the birthplace of our president, who was born there on November 5th, 1960. His parents are Lakshman Rao and Shanta Shervu. His father worked for Atomic Energy of India. Shortly after Arun was born, his parents moved to Montreal so his father could pursue a PhD. During this 2-year period, Arun lived with his maternal grandparents in Mysore. His grandfather was the head of engineering for Atomic Energy of India. Here are his parents shortly after their wedding in 1959. This is a picture of Arun's grandparents holding his baby sister Arati. Here is 2-year-old Arun standing in front of his grandparents' house with his aunt. These are 2 pictures of Arun and his cousin Basanta, who is 6 months older than him. In the bottom picture, you can see that Arun is wearing a dress. He is not sure why he made that fashion choice, but you might see a picture like this again. When his father saw that picture, he was very unhappy. Arun's father was very driven and instead instilled a strong sense of competition in young Arun. And this is a picture of Arun before going to school. When his parents moved back to India, they lived in Bombay. His sister Arati was born in 1963. Arun and Arati have always been close. This is a picture of their young family, as well as some pictures of Arun and Arati on a swing and going to a pirate-themed party. While living in Bombay, he went to elementary school at the prestigious Don Bosco School for Boys. On one occasion, he forgot to get his report card signed by his father, so he decided to forge his father's signature. Even though he was the top student in the entire 3rd grade, he was paddled in front of the entire elementary school. So he never did that again. Outside the classroom, there are many stories of young Arun running on the rooftops of neighborhood homes and garages while playing games with his friends. In 1968, the family moved to Montreal. Academically, Arun was placed in the 4th grade. When they realized he was only 7 years old, they moved him down into the 3rd grade. Here's Arun with his sister and mother at their home in Montreal. Along with the new school, Arun tried a new sport, ice hockey. According to Arun, the coach decided the best position for an Indian kid who couldn't skate was goalie. Now, Arun assured me that no pictures of him playing hockey exist, but I was able to find this one. In 1971, the family moved to America and they lived in the Bronx. These are class pictures from the 6th grade and the 9th grade. It's also a picture of Arun as a Boy Scout. He finished the 7th, 8th, and 9th grades in only 2 years. In 1974, they moved to Larchmont, New York, and he graduated from Mamaroneck High School in only 2 years. The next stop was Princeton. He entered the freshman class at the young age of 15, but he swears that he had a real mustache by the time he started college. The top picture is his graduating class of chemical engineers in the class of 1979. This is an appendix from his senior thesis, and he said he has no idea what that actually means. But of course, he graduated magna cum laude. The final 2 pictures are of Arun and his 4-year roommate, Stephen Strogatz. The first is from 1979, and the second is from June of this year. They remain lifelong friends. It was on to Cornell Medical College. He joined the MD PhD program, but after 2 years, he decided not to pursue the PhD, but continued on with his medical school class. This is Arun in his freshman class play. He also enjoyed playing sports in Central Park with his classmates. This is Arun with his medical school best friend, Mace Beckson. Mace is a psychiatrist in Los Angeles. Arun said that he saw him recently, but he did not disclose whether it was as a friend or as a patient. He graduated in 1984 and was off to California. He was at UCLA from 1984 to 1992 for residency and fellowship. He spent 3 years in the lab on various research projects. Two of his mentors are Dr. Wes Moore and William Quinones Baldridge, whom we have the pleasure of enjoying his company this weekend. This is Arun with his lab crew and his graduating class of 7 chief residents. The best photo is of Arun with his son Nikhil, who is currently a surgical resident at UCLA. They're both holding their numerous UCLA surgery awards. The next stop was UT Southwestern, where Arun spent 3 years as an assistant professor of vascular surgery. He worked with Pat Claggett, Jim Valentine, Stuart Myers, and all under the direction of Chairman James Carrico. Arun finally found his forever home when he moved to Atlanta and joined the practice of Doctors King, Hafner, and Awida in 1995. It was culture shock at first, but he embraced what he calls the life of a country vascular surgeon. The group evolved into Vascular Surgical Associates and now employs 12 vascular surgeons. This is a picture of the group. Dr. Stein joined after the group photo was taken, so he's pictured to the side. Arun and Indira met in New York City in 1986, and they were married in 1987. These are family pictures around the time of their wedding. As part of the wedding ceremony, the brothers of the bride are supposed to convince the groom to stay and marry their sister. In this case, Indira's 6 brothers told Arun that if he knew what was good for him, he would run away. Arun simply said, "If I do that, she will kill me." Life took a tragic turn on New Year's Eve in 1988 when Arun's parents were murdered. Arun's mother had a strong influence on his life. She began medical school in Grenada the year after he started medical school. At the time of her death, she was completing a geriatric fellowship, and her goal was to open nursing homes for the burgeoning South Asian population in the New York and New Jersey area. Here are 2 pictures of Arun's parents. The bottom picture was taken at the Westminster School in Atlanta, where Nikhil and Samir both graduated. This is at the dedication of the Chervou family courtyard in memory of Arun's parents. Nikhil was born in 1991 and Samir was born in 1992. The boys were always sharp dressers and learned how to tie their own bow ties. These are pictures of a happy family. Travel has always been an important part of their lives, whether it's tandem hang gliding over Lake Lucerne in Switzerland, going into a shark cage in South Africa, whitewater rafting in Alaska, or deep sea fishing in Hawaii. And the middle picture is Arun with his boys in Italy. Here are Arun and Indira at the Taj Mahal shortly after their wedding. Arun took a picture of Indira while biking through Holland. He certainly has an eye for color and beauty. This is a picture of Arun and Indira at a wedding of a med school classmate's daughter in Jamaica. For those who don't know, Indira is a nephrologist with Georgia Kidney Associates. So she tells Arun what to do at home and at work. Arun and his boys are passionate about football and cars. This is the famous sports car garage at the Chervou house. Here they are tailgating with the real deal Evander Holyfield at an Atlanta Falcons game. And here's a family picture from Super Bowl 51 in Houston. Nikhil graduated from the Westminster School in 2009. He played lightweight football at Princeton and majored in chemical engineering. He then went to Georgetown Medical School, graduating in 2020, and then headed west to UCLA for his surgical training. Nikhil married Joy Hand in July of 2018. They welcomed a son named Theodore in January of this year, who is the most well-behaved baby I think I've ever seen. Samir graduated from the Westminster School in 2010. He then graduated from Georgia Tech in 3 years with highest honors. He received a master's degree from Duke and then started medical school at Tufts in 2016. Tragedy once again befell the Chervou family when Samir passed away on May 1st, 2019 in a drowning accident right here on Lake Oconee. Samir was loved by his classmates and faculty. He often wore a bow tie, as is depicted in this drawing of him by one of his classmates. This is a pin designed and worn by his medical school classmates. You'll also see Arun wearing that same pin. Samir received a posthumous MD degree from Tufts and was elected to AOA with his medical school class in 2020. Some of Arun's happiest moments were going with Samir to beer festivals, concerts, and football games. Here are some other notable professional achievements. It should be no surprise that he was first in his MBA class. He was also named to the Atlanta top doctors list, but he's not even sure what that really is. Enough about that. Who is our president? Well, he loves a lot of things, as you can see, especially his grandson. He told me recently that what we do is hard and it's very stressful. Life is too short for that, he said. So he encourages all of us to invest our energy into our friends and family. But who is the real Arun Shervu? Is he Pancho Villa? Is he Elvis? Is he a flower child? Or is he Diana Ross with the Supremes? Delivering his famous performance of Stop in the Name of Love. But here's our president hard at work. And finally, it is my distinct privilege to present to you the 11th president of the Georgia Vascular Society and self-proclaimed sex guru, Dr. Arun Shervu.
Wow. That's a really hard act to follow. And he doctored every single picture. So I just want to tell you that none of those are real. So what I want to talk about today is a topic that's dear to my heart. And I had originally was going to talk about a different topic. As I started thinking about this, I really want to talk about the challenges of our current day vascular practice. I want to welcome all the invited discussants, our special guest, Dr. Dalsing, all the members and families to this, and I hope to impart some words of wisdom. I can't be, I don't have an hour or two. I'm not planning to spend that to go over things in detail, but I really wanted to bring up some points. So our outline, I really want to talk a little bit about our inpatient care, outpatient care, and specifically the role of OBLs as some of the discussion has happened recently, burnout, diversity, and really talk a little bit about my family who are so important to me. So one of the things about inpatient care, almost worse than a baby kind of crying in the middle of the night. Hello? I don't think that's working.
Hi, thanks. This is Billy Walker. How you doing today, sir?
Great,
thank you. I'm calling you because I have a patient and a 63-year-old female on Devon Hospital.
So our things from the transfer center, and actually the Perfect Serve didn't play, but those sounds in the middle of the night are horrible. And one of the things I would really say about the transfer center, and there are 4 major health systems in Atlanta, but we also get transfers from multiple other places. And one of the things I would like to say is that we need to communicate with each other. We're a small vascular surgery community. If you really want to transfer somebody and you're not in these 4 major ones that usually get all the transfers, please talk to that person why you're doing it and why you're transferring. If you can't take care of it, we'll take care of it for you. But I would really, communication between vascular surgeons is important if you can't take care of something. I think that's really important. We do ER coverage, we round on our patients, we supervise our APPs, residents, and nurses, and also consultations, and I'll come back to that, both on the floor and intraoperative, and those are important. We work on operative cases, elective, emergent, and some of these are interventional, some of them are hybrid cases, obviously. So there are a lot of reports about consultations, and this is one looking at the financial value of vascular surgeons by Johnson et al. And the services requiring vascular assistance. And in this case, so many of them are spine exposure and other procedures. But I think in our case, our inpatient care, most of our consultations are really hemodialysis, neurointerventional and interventional cardiology, especially as that has become a much bigger field with ECMO and Impella and some of the newer devices coming out. Obviously, cases for peripheral vascular disease, aortic disease, aneurysms, dissections, venous disease, vascular trauma, carotid artery disease, and spine exposure is typically more of an elective consultation. So it really has changed our practice. And what do these things do? They make for unhappy patients as families because these are unplanned cases. They delay or reschedule elective cases. We often have to cancel office patients if we can't find somebody to take care of it. There's increased mortality and morbidity for these unplanned cases. Bleeding and ischemia are the two major issues when we get called to the OR. And again, may require a hybrid or intravascular or endovascular approach, so that sometimes if we don't have a hybrid room, it may make life more difficult. And I think all vascular surgeons have these issues. So what is the worth of vascular surgery, right? There have been some, Powell had this thing looking at short supply of vascular surgeons. Over a third of hospitals are recruiting. Many institutions only look at a profit or loss statement based on professional fees, but don't really look at what the professional service versus the technical revenue generated. And that's an important aspect that I think that a lot of institutions are unable to look at. The contribution margin from a full-time equivalent is over 1.5 million. And probably even higher. This is based on older data. And that's a really important part. When we discuss with our hospital administration, I think we often look only at professional fees, not the technical revenue that's being generated for the hospital, but also how much we help everybody in the hospital, how much we do. And I think our worth is still not being recognized. So then let's go to the outpatient aspect. We evaluate outpatient patients, we have a vascular lab, many of us have a venous practice, some of us do wound care, prosthetics, as well as an office-based lab. And I think that's really an important, these are so many ideas and so many things that we do on a regular basis. It's surprising that we can handle it all. So I want to talk a little bit about communication, really. One of the things Dr. Quinones brought up is really examining patients. I've got to tell you, and I was telling somebody else a story, that I have medical assistants that work with me on a regular basis. They know to get the patient undressed. But when I have other medical assistants that are not regular work, they're really frustrated that say, why didn't you get the patient undressed? Because a lot of times I seem to be the only person that's actually touched them. I've examined them. If they come in for carotid disease, I'm trying to feel for an aneurysm. I'm looking at their lower extremity pulses. And as medical students and residents, I would strongly advise you just don't go on the ultrasound that's being done for that reason. Please look at the whole patient. People with vascular disease have multiple issues. Just because they have carotid disease doesn't mean they don't have lower extremity vascular disease, doesn't mean they don't have aortic disease. And if I have one lesson to tell you about that, that's what I would know what the femoral pulse is. Don't just document the distal pulses. So speak to families and the patients using language that they know. Take time for an informed consent. Sit down and talk to them. I use a lot of handouts, drawing. The other thing is I show them their imaging studies. If I have a CT scan, there's a recent paper from a few years ago saying there's no added improvement in patient satisfaction if you show them their imaging studies. I don't think that's really true. I think they really appreciate that you've shown them, you've taken the time to show them what an aneurysm is, what their aneurysm is. If they've had a CT for their carotid, show them what you're looking at. Answer questions as best as you can. And if you don't know the answer, tell them you don't know the answer. You don't always know everything. So next, I'm going to just show some slides. I mean, these are too busy to go over, but the next thing is really the role of OBLs. There's been a lot of criticism about Plotnikins. And as part of my discussion with families, when I start talking about doing these peripheral procedures, there's a big difference between claudication and people we do for limb-threatening ischemia, obviously, right? There's a huge difference. The natural history of claudication is on the whole pretty mild, so a lot of them are stable claudicants. And there's a whole host of recommendations for medical treatment for intermittent claudication. And this is from Michael Conti's, guidelines, and guidelines are guidelines. And as a short history, Michael Conti and I talked years ago. We were actually in intermediate school or middle school together. I did 7th, 8th, and 9th in 2 years. He did actually 7th, 8th, and 9th in 3 years. It was a special program. It was an enriched program. So that's why he is where he is, and that's where I am now. So, but Mike and I have known each other for a number of years. And, when we talk about interventional treatment for claudication, I'm relatively conservative. Maybe I'm just old. And one of my partners, Dr. Hafner, would agree with me. I mean, we're all very conservative about doing interventions for claudication. And I think people have to show us they need it and want it before we do things. And I strongly believe in an exercise program. I strongly believe in trying to do smoking cessation. I know it's not very successful. So there have been a lot of criticisms for intervention for intermittent claudication, and Bath really talked about PTA, stents. Only 32% were free from recurrent symptoms at 2 years, but I think that's really partly based on who you choose to do the intervention on, and I think that is the absolute most important thing. Who you choose to do intervention on, and who you continue to watch and continue to exercise. There used to be an old story. I remember when I was a junior resident, Dr. Moore told somebody, and Westwood is about, 15 miles from the ocean, telling somebody to exercise for claudication, and the patient would come back every 6 months and talk to him. And in 5 years, he fell into the water. So, I mean, that's kind of an interesting idea. So, interventions for claudication, there's been a lot of this recent paper from Hicks from a few years ago talking about, a lot of people are getting intervention very quickly after their initial diagnosis. However, one of the important things in this paper is the majority of physicians follow the guidelines. All right, and I really want to stress that. Outliers were people who operated too early, and then kind of a stretch association between higher early PVI rate and high volume ASC or OBL procedures, so that they were used for financial gain. And I think I really have a hard time with that concept, and so papers like this, and especially discussion in the media, lead to articles that are in the New York Times, which really are bad publicity. It does not measure vascular surgeons as the provider, but multiple providers and multiple specialties do good work. I mean, I think we have to recognize that. They're bad actors in multiple specialties. Patients are starting to ask whether this modality will be used and whether they want this modality or not. And really, it's patients' families, more the younger family members that are really more tech savvy. And questions of whether multiple procedures are done or will they be required? Why an OBL and not in the patient setting? And I'm going to answer some of these. But these lead to mistrust of physicians, and patients then delay seeking care to the point where they're really going to chronic limb-threatening ischemia. I've had actually some patients with CLTI that say, I'm not sure I want that procedure because if you're going to do it this way. So I think that gets very difficult and gets to the heart of the problem. So Dan McDivitt is one of our former presidents, and he's one of the co-chairs of the council to the SVS on private practice. And OBLs as a site of service. I mean, he had a couple of interesting comments. they're not high reimbursement settings. They require significant capital investment. One of the ideas is that if you get investment and you get loans from some of these other companies, device companies, then you're a bad person. And I think that's not really, a topic. You get a loan from somebody to open up a space. Not everybody has $1.5 million to open up one of these OBLs. You have to rent, buy space, you have to buy imaging equipment, there's the ultrasound, crash carts, ultrasounds. It requires a significant amount of investment in capital. You have to hire the staff, radiology techs, nursing staff. You got to get all the sterile plaques, all the disposable stuff, balloons, stents, atherectomy devices, if that's what you want to use. And the reimbursement in the OBL is anywhere from 25 to 50% less than hospital outpatient department. So that ties into it. So the difference between working in a hospital outpatient department, especially for somebody in private practice, is that you get the technical fee as well, as opposed to what I get paid. But more than that, and I'll talk about that in a second, is the cost to Medicare are less in an OBL, and people don't want to recognize that. Insurance companies have tried to move things to an outpatient setting for that reason, but now we're getting beaten for the same reason. So there's been a lot of commentary in SVS Vascular Connect over the last month or so. And I want to say the first thing is we should not bully each other. We need to have a scientific discussion. We need to make sure that we're collegial. And I think before I say anything else, I think that's really the most important things. But OBLs are more cost efficient, savings for insurance company. They're more time efficient. I got to tell you, I can do 3 arteriograms in 2.5 to 3 hours, and some of my partners can do it in an hour. I'm kidding. But what takes me a whole day in the hospital with turnover. Most OBLs are not spas. These are a couple of pictures of what my OBL and my recovery room look like. There's high patient satisfaction. There's timely maintenance of dialysis access. In the old days when we did everything in the hospital, I mean, I was unable to do, declots, and, I would take, I'd be lucky if I get it done by the end of the day, or if I'm doing it after hours, where I can do it in my own OBL. We have to create quality parameters, and we need to be very introspective about how we do in these patients. We need to keep patients out of hospitals. Somebody mentions that hospitals now look more like ICUs, even the level. We need to keep patients out of hospitals. And many hospitals really cannot handle the volume. We're unable to get cases done in the hospital. Otherwise, we need to recognize the real world. Vascular surgeons are not the only interventionalists. We need to hold bad actors responsible and accountable. And we need to hold vascular surgeons as ourselves to a higher standard. And it gets difficult. It's because, we're competing for patients a lot of times. Prior authorization has become a real issue. It's starting to affect the way we practice. Some of these patients, they want either an angiogram, a diagnostic angiogram, and you can't intervene. And a lot of us went away from that. To do a diagnostic arteriogram, bring the patient back, and then do an intervention is what we used to think in the old days the cardiologist did. And that's not the way I want to practice. If I need to fix something, I'd like to fix something at the same time. Using public media does not really help the cause. And I think that's one issue I think the SVS is trying to deal with, is that individual vascular surgeons should not be talking to public media. Use that as the referendum, for our discussions. Industry is not the devil. I said this last night, and really they sponsor research, clinical trials, they support innovation, support new products, and they support meetings like this. I think these are, important for their support. Now, one of the things, there's been this whole town gown thing, academic surgeons versus private practice surgeons. That distinction is gone. I mean, really, in many ways, academic surgeons are also affected by negative publicity. Almost all of them are reimbursed by RVUs. When I first came out in 92, we used to have some people just on the clinical track, clinical research combined, and some people that just did research. There are very few vascular surgeons and very few surgeons that only do research anymore, that have labs funded by the NIH, you know, $2 million, $10 million grants. That's a very unusual thing in this day and age. And it's important, and I want to stress this, majority of vascular surgeons are really performing well-considered ethical interventions. OBLs are not the issue. The choice of technology does not necessarily mean procedures are being done only for profit. Now, I do probably less atherectomy than some of my other partners, you know, but I use it when I think it's appropriate. You know, we have representatives, you know, industry reps at some of our cases. But I got to tell you, if I notice an industry rep is constantly pushing me to one thing, they're not going to be in my room very much. You know, that's not somebody I'm going to value that relationship. And one of the things the SVS is also recommending is further clinical registries, including the VQI. But one of the things I would advocate, Mike and Julie, two former presidents of the SVS, are really make VQI free. I mean, I got to tell you, it's hard to convince the hospital to continue paying for VQI. And when it gets difficult, because you have to hire, if I do VQI for peripheral vascular intervention, it gets really difficult. The volume, you know, I've got to hire multiple people to enter that clinical data. So I think that gets very difficult to pay for it. So the SVS response from Dr. Mills, Joe Mills, who's the current SVS president, I think the first thing I would say, first, do no harm, do what is best for the patient. You know, outliers are definitely there. 200 high volume providers had half the Medicare's atherectomy payments, okay? And medical industry essential, track patient volumes. One of the things that I heard when I first got here, and this may be an Emory thing, start the patency clock ticking, all right? So the first intervention, whatever you do, everything is going to fail at some point. But the first intervention is the most important intervention. So think, decide before you do that first intervention. And try to follow published guidelines, but again, they're guidelines. They don't apply to every single patient. That's where examining the patient, deciding what you do in a 90-year-old is going to be different than what you do in a 50-year-old that is actively working, or, you know, so I think that's really important. Well, what about burnout? I'm at the point where, you know, I've got maybe 5, maybe 10 years that I might want to work. Burnout and depression are common. There's a paper from Don Coleman, Julie Freischlag, I think, was in that paper as one of the authors as well, that burnout is common. 37% had symptoms of depression in the past month. 8% had considered suicide. But, you know, one of the things I'll tell you is those are looking at extremes. How about the people who are unhappy on a regular basis, who are not so nice to other people, who are not so nice when they go home to their families? I think that's probably more common, you know, who snap at things. You get called in the middle of the night, you snap at a nurse, you know, things like that. Some of these lie into unrealistic expectations. I think we've had some young people that have come in to our practice who don't realize how hard we work. You take call, you still work the next day, you take weekend call, you still work. And I think some of the training models where you're on for 12, you're off for 12, I think have sort of impacted on that. And I don't know if there's a solution for that. I tell you, when I was at UCLA, we used to say, you know what the only problem with being on call every other night is? You miss half the cases, you know, and it sounds crazy, but I mean, that's what we grew up on. I'm not saying that's the right way. Flexibility and control, we've lost that a little bit. And I think that leads to a lot of burnout. I tell you, I know my partners and I always feel the administration is controlling us. I work for them. They don't necessarily work for me. Workload, the call, work-home balance is so important. Culture and value of the practice and advancing age. So one of the things I'll tell you is I don't think burnout necessarily is just the older surgeons. It also, we see it in people who are just finishing training. They feel they're burnt out. And I think part of it is they come in not realizing how hard they're going to work in vascular practice. How about diversity, equity, and inclusion? You know, I tell you, I had an interesting conversation with Dr. Freischlag last night and realized how ahead of his time Wes Moore was. Okay. He had a guy from Puerto Rico, Dr. Quinones, as a fellow. He had Dr. An, Korean, as a fellow. Dr. Freischlag was next after Dr. An, Sam An, and along the way he had an Indian. So, I mean, he was pretty ahead of his time, I think, with diversity, equity, and inclusion. So patients want to see physicians that mirror them. All right. And at the moment, as of a couple of years ago, 25% of 5+2 fellows are women, 34% of the 0+5, but very few Black and very few Latino SVS members. And in terms of sexual identity, only nearly 5% of surgical trainees, not in vascular surgery necessarily, identify as LGBTQ+. And this has led to a number of recommendations to the SVS. And I think we need to, take this to heart. We have a committee here, and I have to say, I'm not sure we've done enough for the Georgia Vascular. But one of the things you'll see is we're trying to get younger people to the podium to come up and be moderators, and more women, more African Americans really come up and be representative to the society. And I think that's really an important thing that we have tried to do and we need to continue to do. So let me talk a little bit now more about my training and acknowledge a couple of people. Wes Moore was the chief of vascular surgery at UCLA. He was SVS president in 1987. I remember him sitting in I think it was 1986 for the first boards in the American Board. At the time, as part of the American Board of Surgery for his vascular surgery boards. I don't know how Wes Moore can sit for his vascular surgery boards. It was the first one, I believe, in '86. I was in his lab along with Dr. Quinones from '86 to '89. I didn't really realize that he had coined the term endovascular surgery. His first course in endovascular surgery, not in a patient, was with Dr. Sam An in '89. He implanted the first commercial aortic stent graft in '93. And, he kept telling me for years that something was cooking. He wouldn't tell me what it is. I think Dr. Quinones knew, I didn't. And then right after, 7 months after I'm done with my fellowship, there he is doing his first stent graft. So I missed out. He was on the first on the West Coast to perform a TCAR. And as many of you know, he has this course that many of the residents take. So it's pretty incredible. Here's a picture of Wes and also Wes and William Quinones, along with Wiley Barker, one of the greats of vascular surgery. And thank you, William, for providing this picture. Some 3 great surgeons. I had the chance to meet Dr. Barker more than a couple of times during my initial years there. I want to acknowledge my friend, Dr. Quinones. I spent 3 years in the lab with him doing research on ischemia reperfusion, intimal hyperplasia, and I had an amazing time in the lab. I extended a year because of that. If you look at this one picture of him talking to a resident about films, I think almost every young surgeon is not even going to know what that box is, you know, the files, because everything is now digital. I mean, you probably, guys have probably never seen that. Boy, those are hard to interpret. You couldn't really expand it. You couldn't, you know, blow them up, but that's the way we practice medicine. That's how you brought your films from somewhere else that were printed. The one thing I'll tell you, he's president of the Western Vascular Society in 2012. The reason I put up Beatles and Spanish love songs, I hate listening to Beatles now, and I can't stand listening to Spanish love songs. I probably heard that every case I did. Sorry, Bill. But you know, he was a quick surgeon. He was a great surgeon in the operating room. He taught me a lot, incredible amount, and but I couldn't stand the Beatles. So just to let you know that. So next, I want to talk a little bit about my VSA family before I talk about my personal family. Here's the first picture is of Dr. Owita, Dr. Hafner, and Dr. King, Oliver W. King. In 1987, I think I got the year right, David Hafner joined Dr. King to open the vascular surgery practice. Dr. King had been practicing already with a general surgery group, and then Dr. Owita joined them in 91. And here's a picture at my first Christmas party in 95. I had gone to UT Southwestern and left after 3 years and joined this practice. And it's interesting, when my wife and I were talking to our group before I joined, we came out, and I'll say this, Dr. King had an interesting question for my wife, Indira. He says, we're going out to dinner, we're walking on this path, and then asks, you know, Indira, don't you have to walk like 5 steps behind your husband? And, you know, she had an interesting commentary. My wife has always been feisty. And she says, you know what? My mother taught me well. She told me never to walk downwind from a man. So this is, so I joined this. This is great practice. I was the 4th one, and unfortunately, all 3 of them have now retired. This is our current VSA family, and Dr. Stein is in this picture, and it's 13 of us, you know, in this practice. Is Stein in there? No. I missed it. I missed that last one. So there are 13 of us, and I'm proud to say we have 2 female surgeons in our group, Dr. Lodgegren, Dr. Duke, and who are both here, I believe, today. But we've had we have a number of advanced practitioners. I think I was in the greater than 10 group that we have doing various roles in our practice. And then this is some more of my family. You know, I was chuckling a little bit as Julie talked about older surgeons. Well, these are 2 of my uncles that both do vascular surgery. Dr. Subindra is married to my mom's sister, and he's 82 and still doing veins. You know, he trained, Larry Ollier was his intern, and Bob Batson was his 2nd-year resident when he was a chief resident at Charity. So kind of goes way back. Dr. Satish Babu, and I spelled his name wrong, is at New York Medical College in Valhalla, and he's in his mid to late 70s and still working, just stopped taking call just about a year ago. So I've got a long way to go to meet the expectations of my family, I think, and they both do vascular surgery. I think you saw these pictures of my parents and my sister, and just to kind of finish up, sort of talking a little bit about my family. My parents were both big influences on me in a little bit different ways. My father was more of a very demanding, but also loving and very pushy. He was the kind of person that you know, finished his PhD in nuclear chemistry and physics at McGill in 2 years, 2.5 years. And I never realized that he had to learn German because all the original texts were in German. So he had to learn German and then finish his PhD. So that's pretty incredible. My mom was an incredible woman. Imagine having a bachelor's in physics, a bachelor's in education, getting an MBA, and then going to medical school the year after your son goes to medical school. She was 41 when she went to medical school. She went out of the country to Grenada and did her medical school in Grenada, away from everybody, came back and did a medicine residency, worked like a dog. And by the time she came back, I was at UCLA, so I hardly ever saw her. She met my wife, and then unfortunately both of them passed away in early '88. And I didn't realize how young they were until I became that age. And you think your parents are old, right? We all think our parents are old. And this is a picture with my sister, and the other one is with my in-laws. So, and that was at actually an engagement party when my wife and I got engaged. Incredible woman, very strong, and really taught me a lot. This is my wife, Indira, and some pictures. This is, I think we were going to our UCLA graduation, and she's a nephrologist. She did a lot of work at USC in residency. And one of the things that's interesting about her is that, in India, you did an internship when you finished medical school as part of the training. And then she did an internship in New York. We got married and she came out to LA. Now, one of the things is when you go in California, you need your medical license before you can become a second-year resident at that time. Well, in New York, you don't get your medical license until you've done your whole residency. And she was a medicine resident. So she ended up repeating an internship in LA. And fortunately, the person that was the program director recognized what a great person she was and how talented she was. And so he let her skip second year and do third year. So, but my mother always said, you better be nice to her. She's repeating her internship because of you. So, so that's interesting. There's a picture with our young kids smiling. Picture, the other picture is with my mother-in-law and all of us, who was a absolute saint. Treated her like my mother. This is the two of us biking in Holland. We used to love, we haven't been in a little while, but on some of these back road trips that, different people can have with different skills can, bike different amounts. And obviously that last one you saw already is in Jamaica. So I had a hard time putting this one together. It's my son Samir, along with Nikhil, and the two of them as children, they like to dress snazzy. This is the three, my wife with my two boys at the Coliseum. Samir graduating from high school. Samir on something he loved to do, wakeboard and, all those activities. He was an amazing chef. I mean, God, I don't compare at all. I mean, here he is, slicing the stuff very thinly. So the cars, let me tell you a little story about the cars. I mean, he's the one who saw this Ferrari that was there. He kicked my wife's car out of it because she wasn't in the 400 horsepower club. But one of the things is, he'd come home, he drove this car more than I did. I hardly ever drive it. But so one of the times his friends asked him, Samir, how come you're driving the Ferrari? It's the only one that'll fit my clubs. All right. Now, it's true, if his car wasn't home, it wouldn't fit. But, so I asked him one time, well, you could have taken the SUV. Oh, Dad. I mean, it's like, why would I do that? He was, this is at his white coat ceremony, and he was beloved by his classmates, and they actually did this pin for him, and you'll see that I am wearing it. We lost him a little over 4 years ago. He was about to start his 4th year of medical school, so the boys were at the same year. This is my son, Nikhil, and there he is as a little baby up in Alaska, picking up some moose antlers. He was, the picture there, I hope you can see, are the 2 boys in the band. They were all both very musical. They were in the All-State band. Nikhil was in the jazz band, All-State. I mean, you know, played the saxophone. Samir played flute, the bass, the guitar, drums. I mean, he just had an amazing year. I mean, it's just incredible. I've been meaning to pick up the guitar, and I think I really need to. Nikhil playing lightweight football at Princeton. He met Joy at Princeton, and you know, they are incredible together. Joy is a lawyer. And here it is at an engagement, and then their wedding in Indianapolis, which was 5 years ago. And now we come to my grandson. I had to show some pictures. This is Theodore. You know, a couple of weeks after he was born, Theodore with their dog Kita. I mean, I think they're telling a secret to each other. I don't know. They're communicating. Dressing up for the first game against the Panthers as Julio Jones. And then finally, and now Theodore is also wearing a bow tie. So he's carrying on the tradition. And I got to tell you a little bit about the bow tie. My kids taught me how to tie a bow tie, if that makes any sense. All right. They said, Dad, you got to step up. Because one time I wore one that was, Dad, that's shabby. I said, well, it doesn't quite look perfect. He said, that's how you know that somebody has tied a bow tie, because it's not going to look exactly perfect. It's not supposed to. So, but I've got to tell you, it's been a real pleasure seeing my grandson, who's asleep right now. And it's been really great to serve as president of as the Georgia Vascular. I wish it was the SVS. No, the Georgia Vascular. That was a misstep. But I really do appreciate the honor of serving as your president. And I got to tell you, one of the things is you can always find help. Okay, please use your partners. Please use others to help you. Here is this baboon showing you the way to the toilets. Probably wanted a little tip on the way. Just remember, stupidity is not a disability. Okay, be prepared. Life is not always paradise, and I think many of you know that, but please do stop and smell the roses. Thank you.
Thank you, Dr. Chavou, for certainly a moving presidential address. In honor of his outstanding year of service as our president, I would like to present him with his plaque from the Georgia Vascular Society.
Oh, yeah. So if people want to pick up a box lunch, and there's video presentations. So that's the last thing. And then everybody knows their schedule for the sports for the afternoon. All right. Thank you. We'll take about a 10-minute break to get lunch and come on back. Thanks.
Thank you for having me here today. I'll be discussing insights
Perfect. All right. If we can get everyone back in their seats. Lost a few to the sporting clays and whatnot. We'll get started with our first presenter. I think it's Dr. Badia. There he is. All right. You gonna say? No, you're good. You're good. Never want to interrupt lunchtime, you know. It's
Thanks, man. Appreciate it. How are you doing? Once again, thank you, everybody. Appreciate the privilege to speak today. This is a little bit more of maybe a simplistic problem, but it's something I come across a lot in a procedure that I feel is very common, especially to those of us that do hybrid approaches. Today, I'm going to talk about common femoral endarterectomy with concomitant retrograde iliac stenting. And one of the things I noticed when I started doing a lot of these procedures when I was first out is, you know, the way I was trained was you kind of do an endarterectomy, you shove a sheath in retrograde, maybe over wire, maybe not. You get a ton of bleeding. It's, you know, when you watch your division chief or your mentor do it, it seems like they don't lose any blood. But every time I did it, it seemed like I lost a lot of blood. I wasn't getting a good endpoint. So this is kind of a technique that I came up with, and I'm sure other people have done it to just kind of minimize blood loss and make things go a little bit smoother. The concept is to provide a seamless repair between that normal inflow vessel or that vessel that you've stented to the repaired outflow vessel, which in this case is either the external iliac or the common femoral artery. This often will require extension of iliac stents into the endarterectomy, and gaps in the repair can risk disease progression and or thrombosis. The challenges are how do you cross difficult iliac occlusions, but today we're really going to focus on how do you tackle that transition point between the external iliac stents and the common femoral endarterectomy. So there are different ways to handle this transition point. Like I said, you can perform your endarterectomy. Before completing the patch repair, you can insert a retrograde sheath and perform stenting. And some of the problems with that is there is a large amount of blood loss. Now, I'm sure some of you are shaking your head saying, oh, when I do it, there's not a lot. But when I do it, there's a lot of blood loss that way. And at least that was happening to me in the beginning. Also, it's very difficult to see that transition point to land your stent in the proper spot. You don't want to be below the inferior epigastric or the lateral circumflex because you want to save those as collaterals, but you have a lot of blood pumping in your face sometimes as you're withdrawing the sheath. Another way is to perform endarterectomy and patch repair and then access the patch and pass a wire retrograde. This is less blood loss and it's a little bit easier to visualize. However, it is really easy to enter a retrograde dissection plane. Now, a lot of times that's not, you know, that has minimal clinical consequence, but it can still be very frustrating when you're in a longer case to be trying to get wire access up into the aorta and you constantly enter that shelf that exists. So the solution I have is called exposure puncture, endovascular, endarterectomy, and then patch. And I perform an open exposure. I directly puncture the CFA before doing anything to it. And I perform my stenting or whatever my inflow procedure is. And then I open the artery and I perform an endarterectomy, which I extend all the way up to the point where I can see the actual stent. Then I anastomose the patch right to the stent in the artery. The benefits of this is it avoids the blood loss. It's very easy to visualize. And you have a seamless endpoint between the stent and the endarterectomy. The only drawback is you do clamp a newly placed stent. And I can tell you in my practice, having done a lot of these, it's usually of no consequence, of course, as long as you're placing a balloon, self-expanding stent. So here we're just beginning with a standard longitudinal incision over this area. We're going to dissect down and expose the artery. One thing I realized while making this, I am definitely not a director or a video editor, so just bear with me. My hand will cross the screen many, many times. But standard approach here, we're going to expose the artery and then we're going to just directly puncture the artery. Now, there are other methods of performing this procedure. One of them is you can still perform your endarterectomy, place a wire up, and then work around the wire as well. That is one other method that I didn't mention. That works good too, but then you're endarterectomizing around the wire, which I find to be cumbersome. This is just a way to avoid that. Standard dissection, exposing the common femoral artery. It seems a lot faster when I'm doing it myself, but when you watch it, it's not. And then here I'm palpating for a soft spot and simply just going to gain access via a small micropuncture needle.
the wire goes up, we upsize to a 6 French sheath. Now this, sometimes you're occluded down to that point. I will take my time to expose up to a point where I think I can get it. But the key here is making sure that you puncture very, very low, close to the profunda as possible, because you want all that room to withdraw your stent to be able to bring your iliac stent down as low as possible. And here we're just upsizing to an slightly oversized sheath. And then we're going to move on to the endovascular portion of our procedure. So for this patient, and I won't spend too much time on this, he had a long segment occlusion of both the common, the external, and the hypogastric on this side. Took a little bit of time, and I was able to get across with get partially across with an 018 wire and a catheter. In this case, I used a second catheter to come up and over from the other side, and I actually got the wire through into the other ipsilateral catheter. How I usually do it at this point is I will floss the ipsilateral catheter to the other side to ensure that I'm in true lumen. Withdraw, now it's on the contralateral side. We're going to withdraw it back into the aorta and flip it up into the aorta to ensure you have re-entry. And then we complete our endovascular repair. This patient required an aortic stent as well. It was very diseased aorta. And then we extend down with the stents of choice. I typically use a VBX in a small aorta with double VBXs for the commons, and then bring Viabonds down into the external iliac artery. The Viabond is nice because, like I said, it clamps well and it's easy to sew to. And this is the completed repair. So now we've completed our endovascular portion, and we're moving back onto the endarterectomy portion. So all of the branch vessels are sequentially clamped. The sheath is then withdrawn after clamping these vessels. And then we'll end up proceeding with our endarterectomy. Here, pot scissors are going to be used to extend the endarterectomy up to the patch point, up to the point where you can see the Viabond, and hopefully you'll be able to visualize it on this screen. The key is getting up to that Viabond and then after performing the endarterectomy, performing a focal eversion underneath the stent to really get the distal end of the stent to fully expand. And like I said, this is not a groundbreaking, huge problem, but it is a small, somewhat simple solution to this. Endarterectomy's kind of just progressed up to the point where you get the stent. Here we're going to transect the plaque and then evert from underneath the stent. Like I said, I am not a director. My hand is in the way a lot on this video, so I apologize. And now you should be able to see the eversion and removal from underneath the stent. It's important to note that here, you do not want to grab the tines of the stent, whether it's a Viabond or another covered stent. It is very easy to unwind some of these stents, so you do have to be careful, but the stent otherwise is pretty forgiving. It's generally pretty easy to sew to. And here we'll evert, and you can appreciate the stent tines from within. There's the stent. Now you have a good visual endpoint. And we're just going to begin our patch repair directly to the stent, taking as many bites of the aortic of the arterial wall in the stent as possible. Routinely, I put a 2 Fogarty in the profunda orifice if I'm crossing the profunda, just to make tacking a little bit easier in case we create a little shelf. And here we are anastomosing the patch. And the bite was taken to include the stent and the artery. Here, we're grabbing the stent from the inside, ensuring that we take a good, healthy bite of the stent itself. It's important to take a good bite of the stent, bring your stitch out, and then ensure, at least on the Viabond stent grafts, there is a little ridge on the end. You have to make sure that you tuck that ridge underneath the patch and underneath the arterial wall, or you will have an excessive amount of bleeding and need to repair that. So as we move along, we ensure that we're grabbing good, healthy bites of both the tissue and the stent and tucking the edges of the stent underneath. Overall, it's actually a pretty simple procedure. The Viabonds clamp very well, but it saves a lot of blood loss and a lot of time. And you don't have to worry about retrograde dissecting into a stent. And even when you have a very calcified vessel, it makes it a lot easier. From here, really, we just progress to a standard endarterectomy. So in summary, the exposure, puncture, endovascular endart, and patch provides a seamless transition from the stented portion to the endarterectomized portion. This reduces blood loss and maximizes visualization. Thank you very much. Appreciate your time. Dr. Shervo, are we here or no? There's no. Yep. Okay.
Thank you for having me here today. I'll be discussing in situ laser fenestration of endografts in the visceral aorta. I've got no financial disclosures. I'll be discussing the off-label use of multiple devices. The problem: prior endovascular aortic aneurysm repair or surgical aortic repair creates challenging anatomy. In situ laser fenestration allows the use of multiple versions of endografts and manufacturers of endografts to create proximal and distal seal zones while maintaining patency of the visceral aorta. Our first case is a 71-year-old gentleman who presented to us with a symptomatic aneurysm after prior endovascular repair. He has a 10-centimeter juxtarenal aneurysm after slippage of a prior hook device with a thoracic cuff. His graft is filled with thrombus in the infrarenal segment, and his iliacs are somewhat tortuous. Here in the coronal view, you can see that his left renal artery comes off essentially at the same level as his aneurysm, and it's just below the right renal artery. So he's got a juxtarenal aneurysm, a slipped EVAR with stiff iliac limbs with tortuosity. He has thrombus within the body of the prior EVAR, limiting the sealing potential in that area. The plan is for a proximal seal zone to be within the descending thoracic aorta, the distal seal zone within the prior Cook zenith iliac limbs, and we're going to use a Terumo Trio long body EVAR. We then performed a 4-vessel fenestrated EVAR with laser fenestration with pre-stenting with the Medtronic VisiPro stent. The VisiPro stent has 4 markers on either end of it that are very radio opaque, allowing easy differentiation of its parallax in vivo. We want to look at the pre-stents in a perpendicular and barrel view, so obtaining those 2 views is essential. Pre-stents must be in the vessel and not in the aorta. We place them at the ostium to allow targeting of the end of the stent. And we've been using a Philips 1.7 millimeter laser and Medtronic Aptus guide for fenestration. The endograft is deployed with intentional coverage of the vessels, and the patients are positioned with their arms up to help reduce radiation, given a large amount of lateral fluoroscopy time. This is our first case. Here you can see we're pre-stenting the left renal artery, inflating a VisiPro stent. Now we're using the Aptus guide to select the right renal origin. The wire is searching, but it does find it rather easily. And we proceeded to stent this as well and completed the celiac and SMA. We proceeded to deploy our EVAR across all 4 vessels. And as you know the stent positions, then you know exactly where to open your bifurcation and the gate of the EVAR as to not be too high or too low. We proceed with ballooning the proximal segment, as this is the only chance to get to balloon the graft before you create fenestrations. And then we proceed with laser fenestration of the superior mesenteric artery. Note that we're in the perpendicular view now. We're going to change to the barrel view. Once we have our laser catheter in place, we want to see this view where the laser catheter is right down the barrel of the artery. I'm going to go back to that view for a second. We want to see this view. Then we go back to our perpendicular view. Proceed to fenestrate, and then balloon angioplasty to fenestration, usually with a 5 or 6 millimeter balloon. We then proceed to place a VBX stent. Here you can see in this magnified view, I want to get at least 2 stent rows within the aorta to allow for overexpansion after VBX deployment. Here's another example of the right renal fenestration in this case. Notice we're trying to get our barrel view right now. Takes a little bit of work. We're not quite right, so you can see we're adjusting the aptus guide. But now that looks pretty good. The laser catheter is on center of the stent. We're coming back to our perpendicular view. Let's mag in to watch the actual fenestration, and boom, goes right through the fabric with the wire going beyond it. We'll mag out, and you see easy placement into the right renal artery. For the celiac in this case, the stent deployment was not perfect, and it was farther into the vessel. As you can see, actually looks rather challenging. But even in this case, now that we know exactly where the stent is, we can make a good assumption as to where the celiac origin is, and we're still able to laser through it. Once we've lasered through once, I like to laser through a few more times to ensure easy balloon passage through the fenestration. So again, we will post-dilate this with usually a 5 or 6 millimeter balloon on the 018 platform. And then follow this with a VBX stent. The VBX is deployed here, and we're inflating our aortic balloon that's larger. In this case, I believe this was a 10 millimeter balloon. And so we enlarge it and then try and straighten it out so as to flare that stent and create a better seal between the graft and the VBX. This is post-CT. All 4 vessels remain patent. The aneurysm is totally sealed. There's no evidence of endoleak. And we've been able to land our limbs into the hook limbs distally. Our next case, another 71-year-old. This patient has had a Endologix device placed with a type 1 endoleak. Immediately noted after the procedure period, a Palmaz stent was placed by the implanting cardiologist to attempt to resolve this. However, the patient continued to have an endoleak. She's also not a candidate for open surgery. Here's her CT. There's a lot of metal over her visceral vessels. Plan for this patient is an angiogram and pre-setting of her 4 vessels, so celiac, SMA, and bilateral renal arteries. Again, using a long-bodied Terumo Trio graft. However, my concerns for this case were being unable to seal into the main body of the Endologix ovation graft, given that its main body is not actually stented, and with that Palmaz in place. So again, we wanted to seal within the iliac limbs. The Palmaz stent obscures the renal artery, and that may make it difficult to fenestrate. However, we were able to do all 4 vessels, and here's her post-CT. Again, all 4 vessels are patent. The limbs are a little compressed in the body of that graft, but we've got good seals within her ovation limbs distally. Our last case here is a 79-year-old gentleman who has a distant history of rupture fixed with an EVAR. He presented with multiple endoleaks. So type 1, as well as a type 3. Here we'll rotate, and you can see that my catheter is just out in the aneurysm. Stage repair, first fixing the type 3 endoleak, followed by the type 1 endoleak. Our plan was to reline his right iliac limb and perform endoanchor fixation of the original graft, and then laser fenestration of the celiac, SMA, and left renal artery, using a thoracic endograft sealing in the main body of the Medtronic EVAR. So we use the Medtronic Endurant iliac limb and a Medtronic Valiant thoracic graft. Here's his post CT. Given his renal dysfunction, this is without contrast. But he was noted to have no endoleak at the end of the procedure and on ultrasound post-operatively. In selecting the correct patients for laser fenestration, the visceral vessels need to be centered on the clock face. The vessels need to be separated to prevent multiple fenestrations through the same area of the graft, so they can't be clustered in the same area of the aorta. This can be performed rapidly for urgent and emergent cases. And for ruptures, one of the techniques that's very useful is you can seal the endograft prior to performing fenestrations. This technique is much more challenging when aneurysmal anatomy distorts the origins of the visceral arteries. In situ laser fenestration is a viable technique to repair challenging aortic anatomy and the complications of prior repair. The longevity of this repair remains uncertain compared to reinforced fenestrations. Failure of fenestration at the original case may require conversion to open bypass or sacrifice of the target vessel. An inaccurate targeting may cause aortic rupture, but is usually self-limited. Thank you for your time and the privilege of presenting today. Thank you for having me here today. I'll be discussing in situ laser fenestration of endografts in the visceral aorta. I've got no financial disclosures, and I'll be discussing the off-label use of multiple devices. The problem. Prior endovascular aortic aneurysm repair or surgical aortic repair creates challenging anatomy. In situ laser fenestration allows the use of multiple versions of endografts and manufacturers of endografts to create proximal and distal seal zones while maintaining patency of the visceral aorta. Our first case is a 71-year-old gentleman who presented to us with a symptomatic
Jessica, medical student. Amelia, third year med student.
The procedure we do for thoracic outlet is a transaxillary first rib resection and anterior scalenectomy, where we remove the rib and the anterior scaling muscle, the rib completely, and also this muscle as much as we can see to open up that space to free up the artery, nerve, and vein. So this procedure, you actually just teach right along as you do that. So I will banter away as we do that, where we'll talk about the patient as we do the timeout, why we're doing the procedure. We'll position the patient so we know they're on a bean bag and they have an arm roll so that they have an axillary roll so they don't injure themselves. And then we'll start, I first assist my fellows so that they learn how to do it.
Incision. Breakdown and we left all the expert content up.
Along the way, if I have students in the room too, we'll have them come over and take a look at it so they can appreciate where the muscles are, where the rib is. I want you to show our student. No, we'll have our students. So Jacob, you want to come over? You're going to see the rib. You're going to see the vein here, the scaling muscle, and a pulsating artery. We even have the nurses look, even the anesthesia team look. And it does give them a feeling of being part of the team so that they actually feel responsible for that patient. And they then can be the leader as they get older and do the same thing for students coming behind them.
And clean it all the way back, and then he's gonna cut the other side.
Everybody loves the undergrad students because they get so excited. You know, they see the lung or the rib and they go, whoa, this is great. And it makes you remember why you ended up doing this for a living. And they also get to meet people in that operating room, whether it's anesthesiologists, nurses, other people, and they get used to, it's almost like a family when they come back to watch.
That's a rib. That's it. It's just a little rib. It's the first rib. I know, it's not big.
Probably the most important thing you need to teach them is when they're doing that procedure on their own later, if they are having difficulty and they can't see or do it, that they call for help, that they know that they are pretty good at it, they've been trained, but they need to make sure they know they need to bring a team in to help them, especially the first couple of years you're out in practice. You really want to make sure that everyone's there to help you because that learning curve when you're on your own is high.
So it went great. She had no issues on our side. You're gonna block her. She'll go to the floor overnight, go home tomorrow, and I'll see her in 2 weeks. Video visit these days and get her in physical therapy, and she should do really well.
At the end of the procedure, we actually do a closing timeout to where everybody says, did this go okay? Were there any complications? Are there any things to watch for post-operatively?
Concerned about it, temperature is normal, no devices, no infusions. One else was 20 cc's probably. ID bracelet is still on and we just need an oxygen check.
Great.
When you're in the operating room, you're focused on the deed, right? You don't get interrupted. People don't call you. You don't get paged. You're really focused right on the prize and you do a really great thing. So it's actually rather peaceful. And maybe it's like when artists are painting or musicians are playing, or if you're running or whatever it is, where you get to that zone where you just get to focus on that one thing and do it the best you can.
So we'll open for any questions.
I'll start that. One of the things I do actually is do the endarterectomy first and sew the patch. And I go through the patch, but what I use is a J-wire. So the J-wire under fluoroscopy so that I am minimizing the chance of having a dissection. I think the one thing is, I think you get a better endarterectomy at the top than when you stent. That's just my personal thing. So wondered what you thought of that.
No, I agree. And that was one of the first challenges when I started doing this procedure was you're still going to have a plaque there and you have a stent in the way, how to endarterectomize around that. Having done it a bunch of times now, it gets easier to kind of reach under that stent and get that focal plaque out, but you really do have to get at least, half a centimeter of that plaque out. And the patients that are kind of an exclusion for this are the ones with the really bad circumferential calcium. Then at those cases, I kind of will do it that same exact way where I will do the endart patch and then stick the patch.
Dr. Molnar.
Same, on that same topic, I always agonize over what clamp to use. Like I usually just put a neonatal clamp up there, but with the stent graft in place, is there a specific clamp you use? Do you use a padded clamp? Do you use a balloon occlusion catheter?
The balloon, great question. Thank you. The balloon occlusion catheter I'll only use if for some reason I have that circumferential patient that I really just can't clamp. Now you have a stent in there, so you're somewhat protected, but sometimes you just can't get the flow to stop. But most of the time I just use a standard non-padded C-clamp.
Questions for any of the other? Dr. Schneider?
Wanted to make a comment on Julie, what you showed there in that video. And I think, as our field changes, I know we're going to talk about our workforce issues tomorrow, but as our field changes and we have now the 0-5 along with the 5 and 2, but it really applies to both. And that is that, that environment that we create really makes a difference in terms of, whether people are interested in what we're doing and interested in our field. So I thought really hit on some good points there. And the other thing is that I think you know, they're all talking to each other. So if we're grumpy and have a kind of a negative environment where we may be doing like the most amazing thing ever. But if the atmosphere is such that not conducive to collegiality and teamwork, they don't get that message. So I thought that was really sharp how you pointed all those things out in very few words, actually.
Especially for me, I talk a lot. Jacob, the young Black man you saw there, is 22 years old. And every year I get a college kid from Wake Forest University that trails me the whole year. And he is now a first-year med student at Penn. I've got one at University of Maryland. I have another who's a third year. They're all going to be vascular surgeons. You know, they have come into that room. He did the video, so he put this all together. We're going to be showing that at the American College of Surgeons too. But when I first showed up as the CEO in an OR too, everybody was scared to death for me to show up. They thought I would yell at everybody, I could fire them, you know, all that kind of stuff. And so we do make it that. So I have undergrad students and med students. And it was funny at Wake, they wouldn't let you bring in undergrad students. And I said, well, why not? And he goes, well, we had one student come in and it turned out the patient went to his church and he knew him. I said, well, don't worry. This patient's like from Austria. This will be good. Okay. But now we have a more, and it is priceless and they can learn. That OR is the best leadership place you can be. Because when everything goes to hell in a handbasket, you know how to handle it. You know how to handle nursing, anesthesia, all bringing the same area. I'll talk about this tomorrow. You can run anything. You can fix a ruptured aneurysm. You certainly can go to a boardroom and get resources, you know. So part of it, I totally agree with you that it's wonderful for me too, because no one bothers me when I'm there.
So Julie, should we use better technology? By that, I mean, you know, we're not very good about using digital cameras on our headlamps, on our loops, you know, to put it up on the screen so we can really, it's hard for somebody to peer through that small space. And you can show them the best way you want, but it's still very difficult. And I don't think we do that enough.
Yeah, I've studied, it's like a bronchoscope down there and a few other things. That hole is so deep. I think the key to this is especially the fellow David, who was with me. Frankly, he's excellent. If you need a partner, he wants to move to California for all of you. He's just fabulous. Plus he's the right size. He's my height. So I really like operating with him a lot. But I think letting them do the case too, they empower him. And he actually did the case on Sam Hartman. You know, he was his third rib and the trainer was there. I said, we're going to do it the way we always do it. And he was like, I don't want to do this. Yes, you can, you know, so I helped him do that case. So I do think we could do more to make it happen. I think it's really hard to project that up just because it's so dark in there to do it. But I think other things, you know, we have lots of things on screens now and making sure everybody understands and appreciates it. I do think though, there is something about letting those kids, the med students touch stuff, you know, letting them touch the rib, letting them touch the aorta, feeling the calcium, seeing that thing come out and all of a sudden you got blood. I mean, and then it makes you excited about it.
Any other questions?
I'm not in an academic setting and I'm become very attuned to methods of learning because I'm the father of a dyslexic child. And so I see your video as a way of incorporating more education in different ways. And I wanted to see, is the academic world, are people open to different methods of teaching, different methods of learning, or is it still the standard ways that we always learn?
Depends on who OR you're in, right? I think we've gotten a lot better. If you're at a really busy academic medical center with a trauma center, many of the students, residents and fellows get promoted in the field. You know, you get so damn busy, you know, so they get to run around and own it and make it happen. We actually have done a lot of training for people behave better in the OR. You know, I've had things thrown at me and I had one fun faculty pull the spleen out and tell me to go find the artery and vein quick. I mean, can you believe that? I mean, he thought that was a way to make me better. Luckily, I found them. But I think we've done a lot better so that we introduce each other now. That has changed things. So we used to say, hey, anesthesia, and they'd answer, right? And so now we know their name. I think we actually empower the people in our rooms to do that. And then if someone does say something bad, we've taught people, we have bystander training where you look at that person and say, you really shouldn't have said that about the patient. A lot of comments we say about patients when they're asleep too, which is not conducive to students wanting to hang with us either. And so I think part of it is us as leaders, even when it's stressful and horrible, that we actually say, okay, it's bleeding now. I need everybody to focus. Let's make this happen. And then thanking people at the end and making it so that everybody wants to come in your room instead of pulling the short straw and stuck in your room. You know, you want to be the person they go, oh, I want to go into Julie's room. So I think it's better. We still have some, I think the younger surgeons coming through are used to that. But we still have a few people that, they shouldn't teach anybody, you know, they just can't do it. They're just grumpy and they don't want to take that little extra bit of time. I probably lost, I don't know, 7-10 minutes showing people stuff. But I tell you, that's 7 to 10 minutes of future vascular surgeons. And that's well worth the investment because they're going to come and they're going to remember how you treated them. We have a Maya Angelou Center at our place, and one of her biggest quotes is, you won't remember always what people said, but you'll always remember how you made them feel. And you want them to leave that OR wanting to be you. And I tell you, if you're nice, you're less exhausted at the end of the day too, because you're actually enjoying yourself as well.
Anybody else? Anybody else do laser fenestration? Here? No? Okay, interesting. You do, Dan. What's your experience been?
It's a fantastic technique. It's not for every case and it's not for everyone. And I do worry that we are going to have some type 1C endo leaks many years down the road. I don't know how you feel about that. But I will say that was the thing I was a little skeptical about doing it the first time was, you know, you don't have a reinforced fenestration. So are you going to leak around that? But there is an hourglass there and I think it'll take many years.
Well, I think the other part that helps with that, especially using VBX as opposed to ICAST. You know, the ICAST is a full stented, covered stent, but there's metal the entire way down, right? VBX separates stents. So what you see happen when you do these on the back table on one of these fenestrations, that the VBX always slips off the metal. So the metal is never at the actual fenestration with the graft. There's always an expanded stent on either side. I think you're getting a better seal with that. Hopefully that means that you won't get these leaks in the future, but we'll see. You know, the reinforced fenestration experience, there's plenty of good data that they work. They do have late failures, they have late problems. Many of those can be fixed endovascularly also. We'll see what happens with these.
But the time reduction with the laser fenestration versus a standard back table is phenomenal. I mean,
excellent.
And you still get a great seal.
Well, I think we're done for today. Thank you all for hanging in there. We're trying these video presentations for the first time. And please make it to the tailgate. If you guys haven't signed up for the tailgate, please do. It'll be excellent.